And I think, Andres, you want to start the introduction of Dr. Middlebrooks, who
Yeah,
doesn't really need
absolutely.
an introduction, but I think it's a good reminder of the tremendous leadership that he represents. So go ahead, Andres, please.
Yeah, absolutely. So thank you, Dr. Middlebrooks, for joining us this morning and give a talk about the new advances that the neuroradiology team has been doing with the newest MRI that we got a few months ago. So Dr. Middlebrooks went to the University of Alabama, got his BS and then his MD over there. Then he went on to do residency at the University of Florida in Gainesville, where he also did his fellowship in neuroradiology. And after he finished residency, he stayed as faculty for a few years. Then he joined the University of Alabama again as faculty. And then we had the pleasure to steal him from over there and keep him here at Mayo in Florida as an assistant professor. Then he moved on to be an associate professor, and now he's a full professor of radiology here at Mayo Clinic in Florida. As you can see there, he has a lot of honors and awards right there. Most impressive are the ones, there's a lot of awards from teaching. So there's a lot of resident teaching awards and a lot of faculty awards, which shows his dedication to education and to advancing the field. Then in the next slide, we have a few publications. These are his most cited publications over the years. And then, as you can see, he has many. And then next slide, we have his H indexes, both from Google Scholar and Scopus. As you can see, he has an H index of 24, which shows his dedication to academics and publications. Now we have made a plaque for you, Dr. Middlebrooks. We'll be giving it to you in the next few days. And it's just a thank you gift for presenting a talk today with us. So Dr. Middlebrooks, please take it away.
The only thing that I can say at a personal level, professional level, what maybe people didn't realize is the fact that the time when he was at UF, he actually worked with Dr. Rotan, you know, and very actively. And it's very important because a lot of the work that he does now at the neuroradiology level, you'll see he's got the influence of anatomy, dissections, but now he's doing it with technology, number one. And at a personal level also, every time that we need something for our patients, just, you know, Friday, you know, or Thursday, we were doing a case where we needed the DTI for motor function and vision function. And he does just amazing. You see a lot of our covers that we've been doing together in some of our journals and the figures. They've been absolutely amazing. He's just a delight to work with, extraordinarily gifted as a colleague, gifted as a clinician, gifted as a researcher. And most important for me is that he's an amazing human being, an incredible father. To see him with his children, to see him with his students, it really fills me with tremendous, you know, hope, tremendous happiness. So thank you, Erik, for being here with us. So take it away.
Thanks, Dr. Gu. Yeah, you know, as a reminder, you know, that I've been here for 5 years now. It seems like not that long ago, but yeah, I remember when I started here, things were a lot different, even though it wasn't that long ago. And I remember Dr. Q saying, you know, we're going to be the #1 neuroscience and neurosurgery center in the world. And so it kind of sounds crazy, but everybody who knows Dr. Q, you're like, hey, you kind of believe this guy. So it was great to, you know, join and be a part of this. And, you know, here we are today with doing some really interesting stuff, kind of advancing our views into the brain using ultra high field imaging. And so this has been around for a little while, but it is only recently clinically approved. And I would say it's been very little focus on ultra high field imaging for the most part in both the research and clinical domains, just because it is a very challenging thing to go to these very high magnetic fields. So I'm going to tell you a little bit about our experience. We are one of, I think, of about 8 or 9 7T clinical scanners in the United States. And so we have really been doing a lot to see how this tool can be expanded to a lot of different uses. And so the first question is, why would we want to image someone at 7T? And this was really, the development of 7T was really driven by, in particular, fMRI, because there are some distinct advantages to fMRI at ultra high fields. And so when we generally think about the image SNR, that it increases it about linearly with the magnetic field strength, but the bold SNR increases by about the square of the magnetic field strength. So huge advantages in bold imaging. and also MR spectroscopy. And so this is related to greater SNR, but also separation of different metabolites at higher field strengths. But it turns out that we see a lot of potential to do a lot more than just fMRI and MR spectroscopy. So I'm going to talk a lot about that. So the scanner, if no one has seen this, is, as you can tell, is quite a bit bigger than a typical 3T scanner. The bore size is 60 centimeters, so that's about equivalent to kind of a smaller bore 3T scanner. But the bore length is much longer, so patients actually go really far into the scanner. And the weight is fairly impressive. It's about 25 tons, which is about about 5 times as much as a typical 3T scanner. And because of the size of the scanner, and then off to the side here, this room is the equipment room with these huge power amplifiers and everything that drive the magnet. It ends up requiring about 3 times the space of a normal 3T scanner. So it's a pretty large system. Some important notes about this is that it's actually only approved for imaging the brain and knee. And we'll learn a little bit more about why that is as we move forward, but important to keep in mind. There are rigid safety standards for metal and implants, and a lot of this is just related to the testing that has not been done. Obviously, there's so few of these scanners. The industry has very little, desire to spend the money that it requires to have implants approved at such a high field. As most of you know, even 3T, we know a lot of devices are safe at 3T, but do not carry a label for such. But it depends, depending on the site, these standards are different. So some places, if you have anything in your body, they will not image you on a 7T period. We try to be a little bit more informed. We know there are, certain things that are, would be safe at 7T. And so we do consider that some things we can scan, but obviously with a very low threshold for safety. So we try to keep things that are questionable or anything like that. We just don't scan. So unfortunately, this does create some limitations, particularly for electronic devices, because even if the device itself doesn't present a safety issue for like heating or torque, we don't know if the device will withstand that magnetic field. So it may not hurt the patient, but it may not work anymore. So those kind of things, we just, there's no data for us to be able to image them. There's an absolute weight requirement of over 30 kilograms. So this does limit its use in like pediatrics. And this is related to the energy deposition. And so that is a hard stop. You have to be over 30 kilos. And then there's a relative weight limit of about 110 kilos, which is just related to the size of the bore. So this is an important thing to note about the 7T scanner is most of our scanners have a RF transmit system in the table. So it's built in under the table, and we use that even when we're imaging the brain. That's where the RF is within the table, and the coil that goes around the head is just the receive coil. So it just receives the signal back from the brain. But there's no such coil in the 7T system. And there are several reasons why this is, but we have to actually use what we call local transmit receive coils. So all of these coils have your traditional receiving element that goes around the head, and then the sleeve that slides over the top is the RF transmitter. And so this means that any coil that we use, we have to have both a transmitter and a receiver. So this is why we see that the head coil here and then the knee coil here, this really means that anything you want to image theoretically in the body or the spine or anything like that will require custom coils that can be quite expensive. And I'll explain why those don't exist in just a moment when you see the physics behind the 7T. But we generally use this 8-channel parallel transmit coil. So this means that instead of having a single transmit element like most scanners, we have 8 individual ones. And we use this in attempts to try to mitigate some of the artifacts that I'll talk about in a moment. But there also, you can purchase separately tuned coils for non-hydrogen nuclei. So this is one area where 7T really excels, is in imaging things that are not hydrogen, which is what is, we typically image in MRI. So these would be things like sodium, phosphorus, and one thing that we're interested in here is deuterium imaging. So you can actually do this quite well at 7T. So it's easy to imagine with the added SNR and all of this that the payoff for 7T would be really high. And but I think some common things that I hear that are important to dispel is, one, people often think that higher SNR means that we can just do things faster and get similar quality images, or we can just do super high resolution scans of anything. And the reality is that's not true. So there are a few things that are important. So for instance, the energy deposition I mentioned is much higher. So This can necessitate having longer scans to reduce the energy deposition. The magnetization is so big that it actually takes a long time for that to recover to baseline. So often we have to extend our scan times because the TR is much longer than we would use at 3T. And then some common techniques we might use, like spin echo imaging, is a really high SAR. So these are very difficult to do at 7T. And then we may have to make some sequence modifications, like changing the bandwidth to reduce distortions, which lowers our SNR. So there's a lot of different factors that go into creating, mitigating some of these artifacts that a lot of them will degrade image quality or prolong the time to scan. And then some of the newer technology that's meant to mitigate some of the artifacts I'll mention in a moment really can increase our scan time quite a bit. So that means all is not positive. So the magnetic field distortions are obviously much higher. So around the skull base, posterior fossa, the orbitofrontal region, those areas where we know that we get these artifacts on 3T as well. Obviously, they're much higher at 7T. The B1 transmit field, so this is the RF transmission, is very inhomogeneous, and I'll explain a little bit more about that in a moment. This is really the biggest problem with 7T. And then, as I mentioned, the energy rates scale roughly quadratically with the magnetic field strength, so they're exponentially higher than at 3T. And then, obviously, when we're imaging things either longer or at higher resolution, we have increased sensitivity to motion artifacts. So this is just showing that magnetic field disturbance. So you can see, particularly around the posterior fossa and the skull base, where these magnetic field distortions are much higher. And you can see that affects our image quality. So you can see here, when we got the scanner, that these artifacts really produced a lot of problems around the skull base, but we were able to mitigate some of those with different sequence parameters. Some things like steady state imaging. So this is something we commonly do, looking at like cranial nerves and things like that. These artifacts, these are really sensitive to what we call these phase artifacts. This just can't be done at 7T. There's just no way. So we have to think of new ways of trying to get some of the same information. So while you would think that this would be highly advantageous for imaging small structures like cranial nerves, the way that we typically would have done this no longer applies. So we have to think of kind of new ways to be able to apply that. But there's another side of this. So the magnetic field susceptibility, while it can be problematic, and also can be beneficial. So you can see here that we can actually use that to see these very small peel vessels. You can see actually the laminations. So you see the inner and outer layers of the cortex. So this can be used to produce more desirable image quality. This was one of Dr. Q's cases, where this patient had on an outside MRI, this small little microhemorrhage here that was not known what this was. But when we did the 7T, you can see this very tiny developmental venous anomaly associated with it. So this was just a small cavernous malformation. So we're able to kind of clinch that diagnosis with the 7T. This is an example of sequences that we use for our DBS targeting. And so you can see this really gives us not only extremely high spatial resolution, but very high contrast of a lot of these subcortical nuclei that we would target in DBS. And this is kind of a whole talk on its own. We do a lot of interesting things in our DBS targeting, but I'm not going to talk about that here today. But if you want to hear more, Dr. Graywall and I actually will be presenting at this conference tomorrow, actually. So if you're interested in learning more about 7T and functional neurosurgery, you're welcome to attend so you still plenty of time to sign up. So the next thing I'll mention is the RF transmission field, and this is really the biggest problem of 7T. So I want to mention it here just so people kind of understand what it is. And you can see that the RF transmission, this field, is very, very heterogeneous. So very bright in the center of the image, and then it fades out as you go away into the posterior fossa in certain areas. So what is this related to? So the RF wavelength that we use in MRI at 1.5 and 3T is much longer, 26 centimeters or longer, which is bigger than most of the anatomy we would image in MRI, particularly the head. But when we go to 7T, the wavelength of the RF is really small, 11 centimeters. So what happens is, now that this wave is smaller than the body part we're imaging, we start to get interference between these waves. So you get constructive and destructive interference where they overlap, and it produces a very heterogeneous image contrast. And so, as you can imagine, the bigger the body part, the more problematic this becomes. So this is why, when we go back to what I said at the beginning, we image knees and brains. These are because, obviously, the extremities and the head are the smallest parts of our body. So that's the reason that we really have not ventured into spine, abdomen, things like that, is this artifact that's already quite problematic becomes even more so. So this is kind of the effect it can have on the images. So you can see this very heterogeneous image contrast. And so we do a lot of things to try to mitigate this, but it still is always kind of a problem. So here are just some example images. So we use MP2 range is akin to MP range image, but there's some reasons we use this at 7T instead of regular MP range, but you can see the higher contrast and higher resolution of these images compared to 3T. The T2 space, again, we can do these at much higher resolution and still maintain a really high SNR. You can see that, and this is one of the things that we use in our DBS targeting as well. You can also see here how it helps with seeing these subcortical structures. And then as I mentioned, these turbospin echoes are commonly what you see is like 2D images. When you see flare and T2 and T1s that are 2D, they're typically turbospin echoes. And we mentioned those there's a lot of difficulty with doing those at 7T. So we use mostly these 3D sequences at 7T. DIR is it's an interesting sequence that is basically where we it's like a flare, but we also invert the signal of the white matter, so you get nulling of the white matter. But because of those two inversions, you lose a lot of signal. So at 3T, these images are extremely noisy, and I know a lot of places don't do them because of how noisy they are. But obviously at 7T, we can overcome that quite a bit. So what do we use 7T for? So one of the first things I'll talk about is multiple sclerosis, and there's a lot of advantages to 7T because of the SNR contrast and the T2 star effect. And some of the societies and experts around the world in MS have actually suggested 7T should be standard of care, but obviously this is difficult because of the amount of 7T scanners in the world. But there are some important imaging findings at 7T. In particular, what we look for is called a central vein sign, a phase REM sign, and then the detection of cortical lesions. So I'll just show you some examples of where 7T is advantageous. And so the central vein sign is simply exactly what it sounds like. We know, for many years that these locations have this perivenular orientation. But the problem is at 3T, we often don't see these tiny vessels. So when we move to 7T, we see that 3T, only about half of lesions, you can see this sign, whereas almost 90% on 7T. And so this carries a lot of added specificity for this diagnosis. And in fact, 7T has been shown to be 100% specific for MS if you use a cutoff of over 40% of the lesions having a central vein sign. And in one study, they found that the central vein sign on 7T was actually more predictive of MS than the McDonald criteria. And you can see here's just a good example of this patient has multiple lesions here, and you can see the central vein and all of these lesions. Here's another one where we see, the advantages here of the DIR sequence, and you can see again, vein running through the middle of the lesion. And then we contrast that to this patient who was a young woman who had MRI, had these lesions, and there was concern for demyelinating disease. And you can see that these lesions, the veins are all eccentric to the lesion. So this was just related to migraines. The advantages of 7T are particularly evident when you get further out. So oftentimes we see these smaller kind of subcortical lesions, and they're so small, the vessels here are so small that you just don't see them at 3T. So you can see this far out, these are heavily magnified, and you can see these tiny vessels even in these very tiny peripheral lesions. The other thing that's important are cortical lesions, and we often think of MS as a white matter disease, but patients can have gray matter lesions. We just don't see them that well at 3T. And 7T actually has a much greater diagnostic ability to detect these cortical lesions, and particularly those that are truly intracortical and don't involve the underlying white matter. So 7T detects over 50% more cortical lesions than 3T. And here's just some examples of the types of lesions you can see. So these leukocortical involve kind of the cortex and the underlying white matter. These are not that hard to see. All at 3T, we frequently will encounter these. But when you get to the intracortical and these subpial lesions, these are almost invisible a lot of times on 3T. So 7T, we actually can identify the majority of these lesions. And here's just an example. So you can see this lesion here is this intracortical lesion. We use this gray matter null sequence as well. You can see the lesion here. And then, on the 3T, there's nothing there. And the same here, these kind of kissing lesions across the sulcus here. You see really well in the 7T, but you don't see them at all in the 3T. We often see patients also sent to us that have a diagnosis of MS and are seeking a second opinion. And 7T we have found to be very helpful in giving added confidence that they actually do not have the MS. So this was a young woman who had these repeated episodes of left-sided symptoms like weakness and paresthesias, imbalance. And because of her clinical history, she was given this outside diagnosis of MS. And she had a few of these little non-specific white matter lesions. But when we did a 7T scan, we could actually see on the 7T, she had these very tiny little cortical lesions with this hemosiderin deposition that you can't see on the 3T because of the volume averaging. And if you look, they're really just all over the place. You see these particularly kind of along the motor cortex, sensory cortex on the right hemisphere, which corresponds well with her symptoms. And so these were all just tiny cortical infarcts that were not visible on 3T. She had actually had several outside MRs, including at the time of her presentation, and the diffusion is completely normal. So I think we have a lot of these cases now of patients with TIAs and things like that who never had anything, their acute presentation on MR, symptoms resolved, and on the 7T, we often see very similar things. So I think we're only seeing the tip of the iceberg with patients who have TIAs and things like that, that they really do have lesions. We just don't see them on 3T, even in their symptoms resolve. So this patient actually, she was a young woman. And so obviously that prompted a workup for why she was having these. And she was determined to have this MTHFR mutation, which is a known risk factor for stroke. So greatly changed her diagnosis. Here is another patient who was a young woman who was seen in a behavioral neurology clinic with a family history of dementia. And again, she has these non-specific white matter lesions, but you can see compared to the 3T scan on the 7T, we see these tiny little areas of susceptibility along the cingulate. You can see they just kind of keep going. These so-called stair-step calcifications. And this is typical of HDLS, or what is now known as CSF1R related leukoencephalopathy, which is an inherited autosomal dominant leukoencephalopathy. And so you can see here the added advantage of 7T. We actually recently had an industry grant to study 7T in this diagnosis. So we're interested to learn more about how 7T can help in this specific disorder. Another common thing we use 7T for is ALS, and this so-called motor band sign on gradient images has been well described in ALS, and it's related to the iron accumulation in microglia within the motor cortex. But unfortunately, this is not specific to ALS. You can see this in older age. You can see it in other neurologic disorders. So we think 7T is actually advantageous for this, and I'll show you why. So the pattern of deposition in the cortex in ALS is actually distinctly different from other disorders because of its preferential location within the central layers of the cortex, which are where the cell bodies of the corticospinal and callosal neurons that degenerate, where they're located. You also see some mild involvement of the inner layers, but it spares the outer layers early in the disease. And we can actually see that at 7T. So we can see these cortical layers on high resolution imaging, and you can see this preferential deposition in the middle layers of the cortex. There's some involvement of the inner layers and then sparing of the outer layers. And so again, here you see the preferential deposition within the middle layers of the cortex. And you can compare that to a patient who just has this physiologic iron accumulation. This is kind of, full thickness, this iron deposition within the motor cortex, as opposed to this, where again, you see the involvement of the middle layers, a little less in the inner layers, and then the outer layers are spared. So it's a very characteristic appearance. So epilepsy is really, I'd say, the reigning champion of 7T. And this is where probably most clinical research has been done in 7T. And we know that patients who have lesions on MRI are much likely to achieve seizure freedom. But unfortunately, we still have a lot of MRI negative patients with conventional imaging. 7T has been repeatedly studied in epilepsy. This is from a meta-analysis that the lesion detection of 65% of patients at 7T compared to only 22% at 3T. So we detect far, far more lesions, even in patients who were previously considered MRI negative, and also assessing the extent of disease. And so this study here, they found that 2/3 of patients who had bilateral polymicrogyria on 7T had been considered unilateral at 3T. So we not only find more lesions, but we also kind of better characterize these different disorders, which again, the inter-rater agreement at 7T is much higher than on 3T, so much more confidence in the diagnoses. So here's just some examples. Here was a patient who, he was a young man. He had been worked up at multiple hospitals for a long time, very young onset epilepsy, and had been considered MRI and PET negative focal epilepsy. And when I show you the arrow here, it's you say, oh, there's something there, but this is common. We see on 3T because of the volume averaging that you get this blurring very frequently. And so again, going back to the confidence and things like that. So at 7T, we see we can get rid of a lot of that effect. So here is where the lesion is, and we can see the sequence that we developed here at Mayo for both 3T and 7T, this edge sequence. We can see the gray-white junction here is blurred out. And so again, you see here in the coronal where you can see this base of sulcus, this dysplasia here, where the thickening of the gray-white junction. And interestingly, this patient many years ago had a MEG outside, and you can see that even with the MEG, I mean, this is like a textbook correlation. You couldn't make this better. But even with the MEG data, they could not find this lesion, knowing exactly where to look. And so this patient was ultimately determined to have a DEPDC5 mutation, and he went on to have an ablation with Dr. Graywall and has been seizure-free. Here was another case that was a little more challenging. So we had this patient who had this PET scan and has this focal area of hypometabolism here. So even when we kind of knew where we were looking, we really don't see anything in that location on the MRI. So we did the 7T, and you can see this dysplasia there on the 7T correlating to the same location on the FDG PET. So again, this really gives us confidence in identifying these lesions. This double inversion recovery sequence has been really highly talked about in the world of epilepsy. I don't believe, in my opinion, that it adds a whole lot over a flare or a good quality flare image. And so you can see here, though, the advantages of our edge sequence over the DIR is it's very hard to see this on the DIR. So we really like this sequence here. We also have the advantage with the high spatial resolution and high SNR of looking at very detailed hippocampal anatomy. And so this really helps us with identifying with patients who have subtle injury to the hippocampus, in particular, having this hippocampal subfield injuries. And so we can see this normal internal hippocampal anatomy. And so what we know from epilepsy is it preferentially involves the dentate gyrus and the CA1 regions. So we can actually assess for atrophy in those regions. And we see patients such as this one, where the overall hippocampal volumes look pretty similar from side to side. But when you look at the hippocampal subfields here, you can see that this normal kind of tapering of the CA1 is lost on this side. So you can really easily appreciate the volume loss within the CA1 region. So this patient, despite the overall volumes of the hippocampus being similar, does have clear evidence of hippocampal injury on this side. We often, too, see patients that were at 3T thought to have an abnormality that did not exist. So this was a patient where we see kind of poor definition of this internal architecture in the hippocampus on the left. And this patient did not have left-sided seizures. So when we repeated at 7T, you can see that it's actually normal. This is just a very common artifact at 3T. Again, another case here where this person was thought to have an abnormal hippocampus, because you see the normal internal architecture here is blurred out, but on the 7T, you can see that it's actually normal. So now I'll talk a little bit about cerebrovascular imaging, and there's a lot of advantages in cerebrovascular imaging. And the first I'll talk about is time of flight imaging. So because the T1 recovery is so long, so it takes so long for the magnetization to be lost at 7T, what happens is the labeled blood actually goes really far out before you lose signal. So you can see that we detect much further out than we do on 3T, but then also the higher resolution in SNR, we can see these smaller vessels much better. So you can see these lenticular striates compared to this side. This was an interesting case of this person who had an MRI that had these bilateral thalamic abnormalities that were thought to represent an artery of Percheron infarction. But we typically, on conventional imaging, we don't see an artery of Percheron, which is this normal variant where one perforator, dominant perforator, supplies both thalami off of the PCA. And you can see on the CTA, there's nothing there, but on the MRA, on the 7T, you can see this occluded artery of Percheron right here. Here again, just comparing the difference between the 7T and 3T. We also do these post-contrast. So again, the added benefit of the high SNR and high spatial resolution, we see lots and lots of small vessels. I like to add these into Dr. Graywall's DBS cases just to make him panic about how many vessels are actually in the brain that we don't see. I mentioned the changes in bold SNR. So this is one of the areas where 7T really shines. And this allows us to improve our statistical modeling because our measured signal is so much bigger. And it also allows us to image with a much higher spatial resolution. So we get much more precision in these measurements. So, I often see in publications these bold maps where it's like the motor cortex and it's like half the hemisphere, right? It's like, that's not real. So we can really see the precision we get for like the hand motor here is where we would expect, and we're actually able to really separate the sensory and the primary motor functions. I mean, this potentially allows us to reduce our scan time because the signal is so strong that which is important because these patients undergoing some of these surgeries with like dominant hemisphere lesions may have a lot of motor mapping, language mapping. It's a lot of testing. So if we're able to cut that down, increase our odds of getting usable data. Here's just an example for language mapping, which again, we often just kind of see these blobs here in the operculum, but we're able to really separate out this traditional pars opercularis from ventral premotor cortex. We actually see these two different parts of the ventral premotor cortex, with the more inferior being the more speech related. And then this kind of motor neuron activation area, which overlaps with the motor tongue area. So these have been well described in the functional literature, but usually not well resolved as we see here. The advantages for bold mapping also extend to other interesting applications. And so this is something that we have here at Mayo. It's called Respiract. And this is a system that is, it's like a rebreather system that patients are fitted in the scanner. And this really gives us a lot of precision over how their PaCO2 levels fluctuate. So we can precisely control this and rapidly control this. So you can see the typical paradigm is that within about 1 to 2 breaths, we can increase their PaCO2 from baseline up 50% or so with a single breath, and then we can bring that back down really quickly. And we also do this ramp, so we slowly increase it over time. And it allows us not only to measure kind of a max CVR response, but also the rate of change and other measures that we think may be more sensitive markers of CVR impairment. So obviously this would, from a theoretical standpoint, be advantageous at 7T. So we're actually the only clinical site in the world that has this system at 7T. And we have started using this in comparing with our 3T patients. And we can see that this is kind of what these normal maps look like. So as you'd expect, we see that the gray matter, obviously greater perfusion than the white matter here. So this is kind of what a normal one looks like. And this was a patient who had moya on the left side, and they had been followed with what is commonly done are these kind of breath hold images. So the patient's just asked to hold their breath in these periodic cycles. And the problem with that is it's very patient dependent. And we know just by holding your breath, you really don't increase your PaCO2 that much, even holding it for a very prolonged time. So we found that even though this is kind of a common standard that a lot of places do this, in our experience, they often seem kind of discordant with what we were seeing in our patients. So this patient actually went on to have the Respiract study, and you can see, in fact, that they actually do have a CVR impairment, and the breath hold is kind of misleading. So particularly these kind of watershed areas on the side of his moya. And we actually did this at 3T and 7T, and you can see that the CVR decrease in the affected side was measured a much greater effect at 7T than we do at 3T. And we can see that in the imaging data. So when you look at the 3T, not quite as impressive that there is an abnormality in this side, but on the 7T, you see these watershed areas affected much better than on the 3T data. So the last thing I'll mention is Parkinson's. And I think 7T really is a powerful tool for the diagnosis of PD. And the key structure in Parkinson's that we're evaluating is substantia nigra. And this, if you recall, has 2 general parts: the pars compacta, the more medial portion that's rich in dopaminergic cells and neuromelanin, and has a very low iron content normally, compared to the more lateral pars reticulata, which is rich in GABAergic neurons and has normally has a higher iron content than the pars compacta. And what we see in Parkinson's is the loss of these dopaminergic cells. So we can actually measure that. So we can do imaging to look at the neuromelanin concentration and also mapping the iron concentration. And so we can see, compared to healthy controls, that in Parkinson's, we have increased iron deposition. So that's we see in these R2 star type images, and then the SWI images. And then I'll show you this neuromelanin in just a second. So the nigrosome 1 is the subportion of the pars compacta that's the earliest and most severely affected in Parkinson's. And a part of this can actually be seen on SWI or T2 star images. And what we see is what's been called this swallowtail sign. So you can see these kind of two dark bands in this brighter area in the middle. This is normal. This is that kind of low iron content in the normal pars compacta. But when you have increased iron deposition from the degeneration, this goes away and it becomes darker. And so this has been described originally at 3 Tesla, but the problem is it's harder to implement at 3 Tesla. We see this in a lot of normal people that you can't see that normal structure. And so 7T really increases our sensitivity and specificity over 3T, particularly our sensitivity is much higher. And here's just an example. So here's a normal, and we see in this Parkinson's patient with the increased iron deposition in this posterior, in this nigrosome 1 area, that this goes away. And then we can also measure this with neuromelanin. So neuromelanin is a normal byproduct of the dopamine synthesis. So it is normally present in these areas like the locus ceruleus and the pars compacta. But this is lost in Parkinson's disease. So you can see here compared to the normal that in Parkinson's, your neuromelanin concentration drops. And there's very few studies that have looked at preclinical phases of Parkinson's with neuromelanin. And we know that this actually precedes their clinical onset. So it's really perhaps one of the earliest biomarkers that we could have. And the problem is this difficult to do at 3T. It's very limited SNR sequence and low contrast. So it leads to lengthy scans, a lot of volume averaging artifacts. And so this is why I think it hasn't translated well to clinical use. But at 7T, we can overcome a lot of those obstacles. And we can see here that this is a multi-echo sequence. So what we see is at this first time point is really weighted towards neuromelanin. And compared to a normal, we see these Parkinson's patients have reduced neuromelanin. And then we see these curves, they drop really quickly over time, which means the susceptibility there is higher. So this is related to the iron content. So low neuromelanin, increased iron, hallmark of Parkinson's disease. So we preliminarily looked at this and found that the sensitivity for the neuromelanin was 87.5 and specificity of 100%. We've made some modifications to our sequences, though, and I think we're even better than this now. So it's, I think, a powerful tool for making this diagnosis. And here's just an example patient where we see this is a nice illustration of the asymmetry of Parkinson's disease. This patient had nearly all right-sided symptoms. And we can see on the neuromelanin that the left substantia nigra, the neuromelanin is much greatly reduced than on the right side. And we talked about this abnormal iron deposition. So you can see here much more abnormal iron deposition on the left side. We see that in these R2 stars, again, a measure of the iron content. We see much greater iron content here, and the same with the T2 star. So we can really easily appreciate these pathologic changes that are synonymous with Parkinson's disease and make this diagnosis with a much more confidence. So this is our 7T team. I certainly, I like to say that I'm more the looks and everyone else is the brains, but I certainly couldn't do any of this without them. They really are the brains behind the operation. And we're fortunate that we have such a great team of physicists and scientists and technologists. So I will end there and take any questions.
Erik, thanks for an excellent talk and your continued partnership. It's always fun, especially when you throw that vascular imaging before my stereo EEG cases, even though Bill doesn't believe me. Bill, do you have any comments? I know you put some comments in the chat, Dr. Tatum.
Yeah, thanks, Sanjeet. So Erik, brilliant talk as usual. And I did mention that, you know, this was a game changer in epilepsy for the neurosurgical treatment. And the reason is that the sensitivity to identify lesions in this cases can actually avert intracranial electrode placement, which carries a higher risk, time, expense, and patients can skip directly to surgery with a lesionectomy if you can see it and remove it. Then we'll have much higher rates of seizure freedom in the end. So, you know, thanks, Erik, and of course, can't do it without Sanjeet. So anyway, thank you.
Dr. Bless, I saw you put a comment in the chat. Do you mind saying?
Yeah, Erik, there's a version of literature on optic nerve lesions, and distinguishing inflammatory optic neuropathies from ischemic, and I just think the technology is amazing, and it will be a game changer for us as well. I think the optic nerve imaging is just fantastic when it comes to 7 Tesla imaging of the optic nerve. It's just a real leap.
Yeah, there's a lot of special considerations with orbits. In particular, one they obviously sit right on top of the sinuses, which is where we get a lot of artifacts. So we have to be very cognizant of what types of things that we can do to minimize those artifacts. There's also a SAR consideration, so there's pretty strict limits about things in proximity to the eye. And so we have to kind of weigh all of those things. The other problem that we often encounter, as you know, even at 3T, that you're well aware of, I know, but just for the audience, is that the eye moves, and when the eye moves, the optic nerve moves, everything moves with it. So for patients to sit still for prolonged times is difficult for them to remain kind of fixed. When you close your eyes, they actually move more. So people often will say when they image orbits to keep the eyes closed, but that actually makes it worse because your eyes actually move more when your eyelids are closed. So it's something we're interested in. I think one of the biggest things I mentioned, the coil technology for the 7T. One of the big advantages, I think, would be having a specialized coil design to image the orbit. So obviously, the closer you get to the structure, the better your imaging. And you can also reduce some of those effects from the RF transmission. So it's something we've been looking into, is having a specialized coil built as well to image the orbit. So yeah, it's a very exciting area. I think the same is true for like the globe itself. I think obviously there's very limited work done and using MRI the globe because there's so many other great tools. But I think this potentially gives us some advantages to explore again what MRI could do in imaging the globe itself.
Eric, one of the comments you made in your talk was about how longer times lead to more difficulty, especially with patient movements. Now, in some of our functional patients, like our tremor patients or Parkinson's patients, where they have movements they can't get around, are you guys doing anything to combat that in 7T?
Fortunately, because of the size of the coil and the scanner, that there's not a lot of room. So most patients are fit pretty snugly in there. We also use dielectric pads when they fit. So most patients are in pretty tight. It can be a little bit uncomfortable, I think, sometimes for prolonged imaging. So our techs are really good at being sure, very simple things like with the earphones, like if their ear is kind of bent, and the patients often, being stoic, will not say anything because it doesn't really bother them. But after an hour, it does start to bother you. So they start to get fidgety. So you have to be really careful about positioning, comfort, and trying to kind of pack them in as comfortably as possible so they can't move. I don't know how many people have been in the scanner, but when you're sitting there in a bigger coil, you have nothing touching you. It's kind of hard to keep still because you have really no frame of reference for like moving your head a small amount. So by things simply just kind of gently pressing on them gives them a much better reference that they're keeping their head still. But as you say, some patients can't control it, right? So those are problematic. And I know Dr. Graywall has seen some of these cases where patients that do have a bad axial tremor or head tremor, it's very hard to keep them still. And, I know it's not their own fault, but so some patients are harder. Some of our patients that have like extremity tremors and things like that, they may not be as problematic. And one thing that we, sometimes is not considered is when you talk about Parkinson's patients is timing their exams with their medication schedule. So you really want them at kind of, the peak medication effect when they're going into the scanner. So, little things like that can help with, getting good images.
Thanks. I think Dr. Barrett had his hand raised.
Hey, Kevin.
Eric, thanks for that excellent talk. And it's great to see the diversity of applications as it grows. I was wondering, could you briefly comment on what we're learning about the role of 7T in patients with traumatic brain injury, specifically mild traumatic brain injury, and the patients that we see with persistent symptoms after a concussion?
Sure. Yeah. So I think that, I show a lot of the gradient images, so like with the SWI, that's an area where 7T really shines. the added gain of 7T is huge, not only in the resolution, but also detecting those small changes. And we've actually seen many cases where patients had 3T scans and then had 7T scans. Not necessarily TBI, but just in general, where we see very small susceptibility things that we couldn't see on the 3T scan. So when it comes to detecting those, I think will be much greater. Some of the other tools that we talk about, though, in the TBI world that are interest are with like DTI. I didn't mention DTI, and there's a reason. DTI is one of the things that actually is not good at 7T. It actually is not as detrimental to DTI. And the reason is because the magnetization, it decays so fast at 7T that your signal goes away really quickly in these diffusion images. So it really makes it hard for it to compete with some of these newer 3T scanners that have big gradient systems. And so I think that could change in the future with improvements in the gradient coil technology for 7T, but that's probably pretty far away. The other is that in quantifying these things is a big problem because of that inhomogeneity in the magnetic field. That will translate over into any kind of quantitative imaging. And so what you would see is, even if you took one person, put them in the scanner, and then did it the next day and moved their head back a little bit or something, and a different position in the coil, and did measured FA values, you would get different results. So so this is where 7T has not quite caught up to 3T, is in the quantitative imaging realm. So we can do tractography and things like that easier because it's not as reliant on those subtle changes in FA. It's simply more of a kind of an anatomic measure than it is a quantitative measure. But any kind of quantitative neuroscience, I think anything that you can think of is going to be a little bit more challenging at 7T. And then, but I think, one of the things that I think has not been explored would be looking at some of these other tools, like with the Respiract and things that may be able to detect very subtle changes that 3T cannot detect. And then obviously, I think one that has probably not gained as much traction in the 3T realm is MR spectroscopy. So there are some new things that are coming out that it can be done at 7T that I can't tell you would be advantageous in TBI because no one's really looked at it before. But I think there's it's one thing that you could hypothesize may reveal something we haven't seen before in vivo.
Thanks.
And then I think we have Dr. Talk and Dr. Sandhu as well.
Great. So a great talk, Eric. This is dreams coming true. This is like the microscope of imaging, basically. I'm interested to know more about vessel wall imaging, where we think this is gonna take us. Is this gonna be a milestone jump forward, or just a small step forward from what we know, especially for vessel wall imaging?
Mm-hmm. I think the answer is yes, and probably not immediately. Typically, with vessel wall imaging, we're using 3D sequences to really get high resolution in every plane. And so what we typically use is what's called space on the Siemens system. And that's one of the images I showed that looked really bad with the signal changes. So that problem, that B1 inhomogeneity problem, is very problematic for space images. So I think you've probably seen some of these cases we've had now clinically. I think we've come a long way, and in the 7T community, I think we've shown people images of this that they really couldn't quite believe we were able to achieve. So I think we've come a long way, but there's a lot of work to be done. So we've been working on this. So the artifacts that we see at 3T with a flow are much greater at 7T. So we've developed some ways to try to reduce that work really well. And so it's, we're kind of marching on trying to get, better and better at doing that, but there's, still some limitations. And when we talk about ultra high resolution too, is at some point you get to the part where just normal physiologic motion of brain vessels and things like that starts to blur your image too. So I think there's more challenges at 7T to realizing the full gain of vessel wall imaging, but I think in the short term, there are smaller gains there. The challenge becomes the how far down you can image. So when you get down into the skull base and the cavernous and petrous segments, those areas are going to be harder to evaluate because of all of the different artifacts. So that may be more difficult.
Great, thank you.
Hey, Johnny.
Erik, congratulations. I just wanted to extend my gratitude for everything that you're doing and kind of put it in perspective for people that, you know, Erik was a champion for the 7T to bring it here. This is not a something that's easily applied clinically, but in just over a year and a half, we've made so many advances, and it's all single-handedly due to Erik. I mean, he has really been an innovator with this. We're looking at, I think, over 700 7T cases, likely more than anyone else in the world. When we first came to pitch for the 7T, one of our 5-year plans was to be a world leader. I think we're already there. Just to give you an idea that even Siemens are asking us for Erik's images because they don't have images that great. So I just wanted to tell everybody that this is really exciting time. This is it's only been a year and a half into it. I'm just really excited about what we're going to be able to accomplish, especially with Erik's leadership in this realm over the next few years.
Thanks, Johnny. Any other questions?
Awesome. Erik, thanks again for a wonderful talk. We're 10 minutes over, but I'm sure if we could keep the questions going, we'd be an hour over. So we're going to let you go. Thank you, everyone. Have a good day.
All right. Thanks, Sanjay.